want to take you on a journey. The year is 2013, and it is a bright, sunny morning in northern Pakistan, in Abbottabad. A young woman, a school teacher, clad in quintessential Hazarewal shalwar kameez and dupatta, walks into the city's biggest tertiary teaching hospital. A gynecology professor, after having a conversation with her, decides that this woman needs to be seated inside the ward on an empty bed next to the other admitted patients. The professor goes from bed to bed, discussing each case, towed by her army of all-female clinical staffers and a batch of 12 to 13 final-year medical students. She stops on this bed. There is a problem. The woman is pregnant, and she has a hole in her heart, so she can't risk being pregnant, which is why herself and her husband have been diligently using condoms for the past 9 years. That's when she first found out she was pregnant, soon after her marriage. Had a miscarriage, went to her physician, who informed her that if she ever wants to get pregnant again, she needs to get the hole in her heart fixed, or else she just shouldn't risk it. And now this woman is here, sitting on a bed with other admitted patients, as a professor of gynecology and an army of all-female doctors, medical students, and the other admitted patients look on. The professor turns from the bed and addresses this audience gathering in the ward. बहुत complicated case है इसका. क्या कर सकते हैं हम? कर देनी चाहिए हमें फिर TOP. You see, TOP is the sanitized, airbrushed, and cleansed version of the otherwise horrific term termination of pregnancy. The Urdu term discourse is somehow too unpretentious for this setting. Besides, whenever we translate words from Urdu to English, they suddenly become more ominous and foreboding. This is an effect that the professor clearly wants. There is a murmur of approval among the audience, despite the fact that they believe they don't really have an opinion or the ability to have one. इसका केस जरा खतरनाक है. मदर की जो लाइफ है वो एट रिस्क है. बनती तो है वैसे इसकी. क्या करूं फिर मैं कर दूं, लेकिन इतना बता रही हूं, अगर मैं जहन्नम के अंदर गई तो मैं तुम सबको अपने साथ लेके जाऊंगी. The audience giggles, fakes laughs, convinces itself that somehow this is a normal and humorous exchange, and pretends that life may move on. But there is a catch. This woman got pregnant despite using a family planning method for 9 years, diligently, almost religiously. And she has a hole in her heart. What this couple needs is a fail-proof contraceptive method. So the professor has an idea. She turns to the woman and informs her, or possibly her uterus, मैं tubal ligation भी करूंगी आपकी. Tubal ligation is a permanent birth control method, almost permanent. You cut the tubes, you tie them up, the sperm never gets to meet the egg, pregnancy never happens, voila. But this woman has a hole in her heart. Can we really put her on an operating table? No one wonders, no one questions, and the professor continues. ट्यूबल लाइगेशन कर रही हूँ मैं आपकी, अभी आप रेडी रहें, आपने खाना नहीं खाना, बस आपसे कुछ घंटे के बाद हम लोग करेंगे आपकी सर्जरी. The woman nods. Does she have a choice? Can she have a choice? What is choice even, given the embarrassing circumstances? And the irony is that isqat-e-haml, or terminations of pregnancies for medical and other unspecified reasons, were ruled legal in Pakistan in 1990 under a federal Sharia court ruling, 23 years before this exchange was happening. The husband waits outside. his wife, pregnant, possibly scared, definitely concerned, and obviously with a hole in her heart, stands inside as she is presented like a museum spectacle to the audience inside. The woman nods in approval, but a male student, 23 years, raises his hand, and he asks, "Madam, इनकी उम्र 27 साल है, हस्बैंड भी कोऑपरेटिव हैं, दिल में सुराख भी है, इनकी ट्यूबें काटने के बजाय इनके मियाँ की वज़ेक्टमी क्यों नहीं कर देते? काम भी आसान है, 20 मिनट का है, तकलीफ भी नहीं होगी, ज़्यादा मुयस्सर भी है, और वज़ेक्टमी के बाद तो वैसे भी मेल्स की सेक्स ड्राइव ज़्यादा ही होती है, कम नहीं होती, तो वो वाला मसला भी नहीं है." The audience waits, stunned, into silence. Here is a man talking about cutting another man's tubes that transport sperm cells from the testes to the seminary glands, and somehow is also acknowledging sexual activity and pleasure in a gynecology ward. This is uncharted territory. How does anybody respond? The professor waits for a few seconds, and perhaps after a moment of some level of intelligent self-reflection, responds with a giggle. "Unse baat kaun karega? Tum?" Everybody laughs again. Somehow that also means approval. The professor moves on to the next bed, and the uterus, with the woman attached to it, awaits its turn to go under the knife later that day. In my over 5 years' work in the sexual and reproductive health fraternity in Pakistan and globally, I have seen this a lot. A specific group of people telling other people how things need to be done. And this group seems to have very specific characteristics that are almost always common in all members of this group. Number one, education. And not just any education, a biomedical one. Now, perhaps even an international development one. An education that has reduced women to uteruses and everything that comes attached with it. And the person that is attached to that uterus perhaps comes later. An education that has reduced women to a number of indicators reported in annual target reports. Number two, age. And by age, I don't just mean a certain number. I mean the generation gap. And I'm really sorry to everyone here who was born before 1980, but I mean you all. And this is the elephant in the room that needs to be addressed. The generation gap is real, professionally and personally. And Gen Xers need to recognize it. In Pakistan, the Zia generation also ushered in a new era of timid NGOization of the reproductive justice movement. Sadly, they have missed the note that that era is now over, and that the new one requires even more courage and bravery than before. Number three, class. We all know who had access to a university education and degree, perhaps up until 2005 when things slightly changed. And the ones, like myself perhaps, who somehow managed to climb this academic oiled pole have had to parrot the sensibilities present in our industries. No one wants to risk losing their job in Pakistan, especially for having an opinion, let alone speak it. And this group of individuals, when it gets together, upper middle class, educated with a biomedical degree, and absolutely blind to their own classism, always echo two philosophies. Number one, population control. Vis-a-vis, we have so many poor people, and they're having so many babies that also happen to be poor, that again have babies, that again happen to be poor. It's poor people making more poor people. And the problem is clearly the making. and not the absence of poverty alleviation efforts or reproductive justice. Number two, uneducated jahil log. They know nothing. कुछ भी नहीं पता इन्हें. शऊर की कमी है. इल्म की कमी है. People don't know what they want. Let us, the educated, the mighty, the non-plebeians, tell them what they deserve and what they need to do. So I did something. In my previous assignment on a family planning and reproductive health mission, I tried to conduct a research based in user experience and participatory ethnography. And what I found was that reality is absolutely different. These assumptions that we've held as supreme and true actually get debunked. Number one, people know what they want. Women associate their periods and menstruation with their femininity. And if they get irregular or they stop altogether, like on most hormonal contraceptive methods, they think there is something wrong with them, that they are sick. Mothers want to be healthy so that they can be better moms to their children. Husbands want to be better providers to fulfill their responsibilities of providing for their wives and children. But the catch is, if they recognize that it is difficult for them to provide for more children, it is also a source of distress, you see. Because manhood is essentially linked with being a good provider. And not being a good provider means that you failed at your own responsibility of manhood. And mothers-in-law across the aisle just want more grandsons, and ideally one granddaughter, so that they can show the world that they have concluded their parental responsibilities and extended their bloodlines. Structures becoming shackles. How do we even navigate the question of choice and agency if we continue to ignore the obvious, that patriarchy has held women and men in reproductive prisons, stripping them away of agency and control, while feeding them a hollow dream of some culmination of a masculine or feminine ideal? The second thing that I found was that people know what they're afraid of. And it's not complicated. These are regular concerns. Women's ability to conduct their practices in their daily lives, their physical and mental health, and their reproductive capabilities. All hormonal methods of contraception give you irregular bleeding that may culminate in having no periods at all eventually. Think periods, but out of order. Not many women want it. Intrauterine devices, a method popularized by the West to be given to lower middle income countries so that poor brown people can stop having more poor brown people, are actually very scary. Stories of them getting lost in the body abound. And somehow, women just don't want to go to a medical provider, take their pants off, lie down on a cold steel bed, spread their legs, have a metal speculum inside of them, and then a plastic device inserted in their uteruses. Doesn't sound very appetizing on a Saturday morning. To us, wouldn't sound very appetizing to them. Women want to know, when they stop using their family planning method, how long will it take for them to get pregnant again? And if their children are going to be normal. In short, does contraceptive or any contraceptive method have effects on my future pregnancy? And last but not the least, given the everyday stressors and the busy routine of women's life in Pakistan, they just want something that is easy and that they don't have to worry about. Number 3, people know about family planning methods. Not all, but some. However, the ones that they want, the ones that they really, really want, are simply not present. Case in point, hormonal implants. 3 to 5 matchstick-like bodies placed beneath the skin of your arm in a procedure that barely takes 3 to 4 minutes. Yes, the issues with periods becoming irregular or periods stopping altogether after 9 months exists in this method as well. But compared to IUDs, discreetly getting 3 matchsticks under the skin of your forearm on a bright Saturday morning somehow just seems more easier. Despite that, up until the middle of this year, the Pakistani government stated that only doctors with an MBBS degree are allowed to place implants in a woman's arm. Midwives and dyes can conduct deliveries. The method that is most in demand is also the least accessible, least affordable, and least available. In New Zealand, when koala bears' population exploded and the eucalyptus forests were almost on the brink of destruction, the government stepped in, randomly picked up female koala bears, and gave them hormonal implants. In Pakistan, our women have to rely on antiquated methods, such as injections and IUDs, methods that have been conveniently pushed on us by the global reproductive health fraternity. So much so that the number of IUDs provided in 1 year is actually a national indicator of family planning success. But the number of women who actually got what they wanted will perhaps be a statistic unknown to us forever. So what I did was, I designed a counseling strategy for my health workers to actually have conversations with people. I call it the AAA framework or the AAA methodology. It is somewhat holistic, tries to place a woman in her social ecosystem, and tries to work with her to understand what her situation is and what is going to be best for her. Number 1, assess her situation. And when we say assess her situation, it's not just assessing the biomedical. What's your age? How many more children do you want? Do you have another disease? But also understanding what her support system is like. Who wields power in her household? Who are the people that she can talk to when she is in distress? Because we need to understand the person as a whole and not just as a sum total of their reproductive functions and organs. Number 2, appeal to their goal. Every individual has a goal, even if it's not as grand as we'd like it to be. It can be something as simple as breastfeeding my youngest child, getting my medication on time, just having fewer joint and back pains, being a better mother, getting back to work. And we need to help women understand if family planning or any contraceptive method would help them achieve that goal. If it doesn't, they don't need it. If it does, we go to the third point, address their concerns. And most concerns about family planning are legitimate and predominantly linked with physical health, reproductive capabilities, and ease of use. In short, concerns that can be very easily addressed. For all hormonal methods, it is irregular periods. For IUDs, they are just scary. So we talk to women and we inform them that period blood isn't dirty blood. And that if there is irregular periodic bleeding or spotting, daily activities aren't hindered. You can shower, you can do whatever you want to. Even Islamic edicts state that no religious activity is prohibited. But there is one thing that is missing in addressing the concerns, and that is helping women choose a menstrual hygiene product that is affordable, easy to use, and waste-free. This is something that is entirely absent from our conventional programs on family planning. You see, the issue here is that concerns with family planning are legitimate. But doctors, because of their class-based arrogance and normative sensibilities on sexuality and reproduction, and especially upper and middle class gynecologist females, have somehow become the other. No one is going to believe you or talk to you if they also think that you do not understand them. And this is a point where all of us in the development sector and the reproductive health fraternity need to seriously ask ourselves, what is it that we truly want? Population control or happy and prosperous communities? Because every time somebody stands up and says that family planning is a Western agenda and we shrug our shoulders, do we forget what is being done to the Uyghur women in China in forced sterilization camps? And has our history deleted the chapters on what colonial settlers did to indigenous women in the USA, Canada, and Australia? Practices of forced sterilization that continue till this date. Yes, family planning has been used as a political tool, and we just can't ignore it. Family planning is also not secular or apolitical. Sex is mediated through marriage, reproduction is mediated through marriage, and marriage is a social and religious institution. Therefore, it should come as no surprise to anyone that social role play or ideas of virtue and sin predicate people's reproductive decisions and the decisions that they take about their marital life. Family planning is also not apolitical. We live in societies built on the backs of the unpaid labor of women, domestic, industrial, and reproductive. Our societies function because a controlled rate of poor people was reproduced annually so that our unequal markets can keep on going. And this is also a reality that just can't be ignored. We can't ignore or divest ourselves from these realities. We need to live in these realities to inform what our modicum and our practice needs to look like in the future. Because as I said, concerns about family planning are legitimate. So what are we going to do about it? I think three things are essential to help us transform our current family planning landscape, which reduces women to uteruses and targets to be reported to the UN and the Bill and Melinda Gates Foundation, to actual human beings with a story and a life and a future. Number one, our healthcare professionals, and especially our doctors, deserve to be exposed to gender-critical and gender-transformative thinking and trainings. We'll go nowhere without that. Innovation and change, and not just in what we say, but also in how we conduct our business, needs to be celebrated, not frowned upon. And if we are truly serious about this ticking population bomb, we need to invest more money and human resources in designing products that are actually comfortable and convenient for female bodies and other bodies that have to use them. Simultaneously, we also require education. Education that just doesn't tell us about the biology of our bodies, but also allows us to understand them, to be proud of them, and to be proud of everything that they're capable of. Without these, we go nowhere and keep running with our head in the wall, with targets in sight, to be reported to international donors. The issue that remains is essentially this, that our current public health programming is not human enough, is not progressive enough, and is definitely not political enough. Our current efforts on family planning are mired by biomedical academic arrogance and classist misogyny, both driven by a generation that is oblivious to change thanks to its organizational inertia and is also very ageist. Any critique of the current model or ideas of innovation are looked at as entitled millennial talk. And to all the young professionals in this room, this is a fight that you'll be fighting every day of your life as you work in the development sector of Pakistan. So the question here is, how long do we, the young generations, have to bear the burden of fixing a problem that we have been given no stakes to fix? My name is Moiz, and I was the student whose hand went up in that gynecology ward. Thank you for coming to my TED Talk.